Hey, welcome everybody. This is Len Calabrese. I recently spoke at AWARE at a fabulous meeting where I spent an hour talking about the challenges of outpatient management of our immunocompromised patients. And Grace asked me to do the executive version. I'm trying to knock this down in about 20 minutes, so let's get going. I'll talk about my views on how the pandemic will end. I'll talk to you about a strategy to help protect our most vulnerable patients, and I'll give you a quick update as of this moment on this day at the end of February of status of monoclonals and antivirals. So how will the pandemic end? Well, nobody knows, but universally agreed that it's not going to just go away. This virus in some form will likely circulate in an endemic fashion. Hopefully with lower pathogenicity. There will be two epidemics moving forward. One, the vaccinated, low mortality and hospitalizations in healthy people, and then the unvaccinated, and then our vaccinated immunocompromised patients who are susceptible to breakthroughs. So the questions on our minds as rheumatologists, are patients more susceptible? Probably, and based on comorbidities and drugs. Do they get more severe disease? Yes, particularly based on comorbidities and drugs. Do they have a different virologic and natural history? Our most immunosuppressed patients do not clear this virus and wind up with long-term shedding, generating their own variants. And finally, the increased risk of severity of breakthrough is something that I will talk to you about, and I'll share some very recent hot off the press data. SARS-CoV-2 is a disease where there are variants, and this is an antigenic drift map. So Wuhan strain over on the left, and then the further you get away are structural variations in the virus. And look at Omicron. It has been subjected to variation, competition, and evolution. And so this most recent variant has threatened our wall of immunity from vaccines. Even more recently, the BA.2 variant, which has trashed through the Netherlands, is outpacing Omicron, probably somewhat more transmissible, not more serious, and people who had Omicron probably are resistant to this, but it just makes the point that we need to know our variants in our area, and I'm going to come back to that in a minute. Well, moving ahead, we're doing our best to get our patients vaccinated, but are they at risk for breakthrough more than the average public? Well, this is a very important paper by Sun et al. In this current month's JAMA Internal Medicine. And as you can see down here, this lowest gray line is the breakthrough rate in the general public. Rheumatoid arthritis is here in the middle. You can see it's palpably higher all the way along, and these are solid organ transplant patients. So there are gradations. This study, which was done in over 600,000 patients, unfortunately, was not based on drug therapy. But it makes the point that breakthrough are more important for our patients than the general public. This past week, we posted this pre-peer review version of our paper, Breakthrough of SARS-CoV-2 in Immune-Mediated Patients Undergoing B-cell Depleting Therapies. We looked at all the patients with autoimmune diseases who are getting rituximab or ocrelizumab at the Cleveland Clinic. We looked at all of them who were vaccinated. We asked how frequently they developed breakthrough and what those outcomes were. And these are the data. Out of 1,700 patients who met that criteria, and that excluded cancer patients, we found 74 patients with breakthrough, about 4+%. Unfortunately, despite being fully vaccinated and most being boosted, over about 1 out of 3 required hospitalizations. Somewhat over 1 out of 5 wound up in the ICU, and 8% died. So the answer is that for our most vulnerable patients, breakthroughs are real. They have severe outcomes, and these are patients that we have to be vigilant against. So with that background, what can we do to protect our patients going ahead? I mean, this is going to be like this way for a long time. Well, we have a vision of what is going to be required to cope with this. And that is summarized in this schematic. It starts with us educating the patient. And I'll tell you what it's all about, but you get it, that they're vulnerable to COVID. Can you recognize it? Can you get rapidly tested? Have your testing materials at home. If you are positive, who's the right person? We've saw it time and time again. When I called my PCP, they said, take this Z-Pak, let's wait a few days. And they missed the window of opportunity. The right person is the person who knows the right care path and knows about the variants in their area. So starting with that educated patient, breakthrough patients may start subtly. They need to know that if they get a cold, they need to start testing, because home tests, rapid tests, are very good if you have symptoms. They need to be aware of the urgency to do this. They know that, less than 10 days for most monoclonals, but the newest monoclonal that we'll talk about, the window is 7 days. And antivirals, it's 5 days. So you can't dilly-dally around. Do they have their tests there? Do they know how to do it? And then the next step is, do you know when to bypass all this and go to the emergency room? If you can't talk, do you have a pulse oximeter? All my rituximab patients have this, and I encourage them all to have this. And then finally, who are you going to call? Is it me, my AP, a triage person, or some other person in your area? First, let's talk about our lines of defense. Monoclonals have served us well. They've been the bulwark of our outpatient early therapy. And I'll show you some impressive data. We had, when we had REGEN-COV, we could give this as post-exposure prophylaxis for people who were heavily exposed. That is now off the list because current variants are resistant to it. What about giving to people when they get in the hospital? Well, this is a matter of controversy. We don't have an EUA for it. There's some evidence for people that don't make antibodies that this may be effective, but that's a different topic for a different day. And then finally, what about pre-exposure prophylaxis with Evusheld? I'll talk about it as we go along. Do they work? This is data from our recent study. These were the 74 patients who, on the left, 53 of which did not get monoclonals. As you can see, almost 50% of these people wound up in the hospital. If you look at the 21 patients who got monoclonal within 10 days, and that was all REGEN-COV because this was pre-Omicron, only 1 out of 21 patients, 5%, wound up in the hospital and didn't even require oxygen. This is the most robust evidence that we are aware of that monoclonals are an effective part of this defense network. It's unfortunate that only 21 got them, and we can talk about that later. So these are the monoclonals that we have at the present time. We have the ones in the kind of brown shading: bamlanivimab, casirivimab, imdevimab, bamlanivimab, and estivimab. Those are the first-line drugs that we used up through Delta. They're gone. They're resistant to it. The new variants are doing this. Sotrovimab was our most resistant drug, and it was very good for Omicron, but it is not very good for BA2. So if BA2 is into your area, it shouldn't be used at this point in time. Tixagevimab and silgavimab is Evusheld, and that is still active against Omicron and BA2, but as of this week, February 26th, the dosing schedule has changed. And finally, we have a new drug on the market, bebtelovimab from Lilly, which is effective against Omicron as well as BA2. So that is the drug that is active now. It's a matter of availability. This slide tells the story of why this is about. On the top here, you can see this is the receptor binding domain. These are different variants and active against these regions. These are the molecules. It doesn't take too many molecules in the spike to knock out the activity of a monoclonal. So here is sotrovimab against Omicron. As you can see, this was the activity against Delta. This was activity against Omicron, almost identical, just a slight shift. But if you looked at REGEN-COV, here was the activity against Delta, and these two compounds are virtually many log phases weaker. So this drug is out. Bamlanivimab, estimevimab, totally out. Sotrovimab was the only drug that was active, but this is getting blown up by BA2. So what about Evusheld? Evusheld is a tremendous advance. You know, pre-exposure prophylaxis, we do it for common variable patients on IVIG. We give it to people who are at high risk for HIV to take antimicrobials before this. And the idea is that for people who can't make antibodies, and this is not a substitute for vaccination, give them this FC modified monoclonal, has a half-life that lasted every 6 months, and they would be offered, you know, a high degree of protection. It's great. We started this program. The drug is in short supply, but we were rolling on this. As of about 96 hours ago, we got the word that BA2 has a somewhat greater resistance, and the dose of 150 milligrams every 6 months has to be doubled to 300. So all of a sudden, we have half the dose. So I don't know what is the availability in your area, so we're still giving it, but people are needing to be boosted. People will need more, and there's not enough of this going around, and that's what we have at the moment. The data on this was impressive. If you gave it to people who were at high risk, they were protected by about 77% in terms of their requirement of getting acute care or developing any symptoms. So for people on rituximab in particular, they are at our first level. I'll show you. This is how we have triaged them at the Cleveland Clinic. B-cell depleting agents, people on tyrosine kinase inhibitors, people that, you know, getting CAR T cells, and people with malignancies on heavy stuff. Tier 2, other hematologic malignancies and common variable. In Tier 3, are other patients, you know, on JAK inhibitors, combination antimetabolites, biologics, solid tumors under active infection. If we had enough, we'd probably give it to everyone. Should we be checking anti-spike antibodies? I believe so, even though the CDC doesn't. And we do it, and people who have no anti-spike are moved up on our list, at least in our own rheumatology clinic. The challenges are limited supply, the allocation, the new double dosing, which cut our supply in half. And will this require dosing after 6 months, or is that going to get redosed sooner? Obviously, we have ongoing concerns about our future variants. So know the variants in your area. We keep track of this. Cassie does that for us. Follow me on Twitter, Len Calabrese, easy to find, and I shout out about the variants on a regular basis. Antivirals, changing landscape of our therapy. If we only had a packet of this in our medicine cabinets for people at high risk, we would be much further along. We're still at a period of time of limited availability, complex distribution, eligibility. Cost, it's not the major issue at the moment. There are 2 drugs that are available, Paxlovid, which is a combination drug of a protease inhibitor and an enzyme inhibitor called ritonavir, which I've used in HIV patients for over a decade. It extends the pharmacologic half-life of the protease inhibitor. This, in the results of a randomized controlled clinical trial, showed that if you gave it within 5 days, 90% reduction in requirement for acute care and hospitalization and death. I mean, that's pretty great, pretty great. So, you know, person experiencing breakthrough who's vulnerable, this offers a lot. There's concerns about this. One, they need to be tested and tested rapidly. I've been having this cold for a week. No, you're too late. Treatment only. It is not prophylaxis. 2 tablets twice a day for 5 days. It is a cautionary because it contains ritonavir. Ritonavir, a very potent CYP3A inhibitor. There's an article in the Annals of Internal Medicine only in the last 48 hours, which goes through this and gives you a flow chart. Many of the drugs are of concern, you know, people on things like simvastatin, or people on, you know, antifungals, or people on calcineurin antagonists, and clopidogrel. These are either non-starters or require major modifications. There are websites to check. If you have access to a PharmD, if there's any questions, do it. Many of the drugs, like regular statins, anything can be held for 5 days, except for a few drugs for particularly vulnerable people. There's some renal clearance issues, but for most people, this is pretty easy to clear the decks for. There's another drug, Malnupirovir. This is a mutagen. If you look at the RCT data, from 90% to 30%. I can't see using this drug unless there's a contraindication or Paxlovid is unavailable. It's easier to give, doesn't have the drug-drug interactions, so it's there. So finally, let's wind up and say it begins with education. Has that patient sitting there, if you develop symptoms this week, do you know what to do? Oh, yes, I do. I have a home test kit, and I'm going to test myself as soon as I have symptoms. And if I get too sick, I'm going to go to the emergency room. And if I'm positive, doctor, I'm going to call you, or you tell me who to call. You, on the other hand, know the variants in your area. You know who to call to get them into monoclonals. And you know about the distribution of Paxlovid in your area. In our place at Cleveland Clinic, I can get Paxlovid. I can't get it at CVS today, but it's coming. And then for those same people, particularly those that are at highest risk on rituximab, you know, listen, I'm sorry to tell you that while everybody's running around wild in the streets now taking their masks off, it's not over for you. And until I get you on Evusheld, you know, you need to be at the highest level of risk. And even on Evusheld, because you're vulnerable for severe outcomes, we need strategies in place. So I want you to, you know, be conscious and, thoughtfully engage in non-pharmacologic interventions. It requires a system. Once you have the system, then we can get there. So whatever I told you today at the beginning of March, you know, may change in the next day or the next week, but it's certainly going to change. And as Heraclitus said, no man ever steps in the same river twice, for it's not the same river and he's not the same man. And that is the COVID river. Follow me on Twitter and I can feed this to you on a regular basis. Thanks to AWare. It's always my privilege to throw in